Day 2 in this emergency operations center. This place looks rough. I refuse to eat another piece of pizza.
Vegetables for all at lunch. Any other updates for the group?
Staff are having a hard time getting in with the road closures. We are working on communicating alternate routes now.
Also, our regular linens delivery is delayed again. Thank goodness for our contingency plans with Larry's Linens for Less.
Larry will drive through anything. We will have to think about if we need staff sleeping accommodations and have the linens to support the need.
Yeah, we are lucky our water is repaired. It sounds like there is significant damage at healthcare facilities in other regions.
Some facilities are running low on resources. We've been asked if we can share some medical supplies with impacted facilities. Our logistics section chief is checking on our inventory. I'm wondering if this will end up being a declared disaster. It's good that we identified a disaster fund to track disaster-related expenses.
The weather report is showing 2 more days of this. We are going to float away. I knew I should have gotten that canoe.
What makes an event complex? Duration, right? People fatigue. I was talking to somebody at lunch today, and you have an event and people start calling in, do you need me in? Can I come in? Do you need help? And the answer typically should be, I don't need you right now, but in 16 hours, if you could relieve the current crew that's on. Duration, definitely. What else? Okay. I think the more novel the event, I mean, how many of us were prepared truly for the pandemic, even though we had a fairly good dry run through H1N1, through what we called swine flu? What else makes it complex? How much of our facility is impacted, how long we're going to be disrupted or down, how long we're going to have to curtail services, and how do we turn them back on, in what order? Right? This is higher level thinking. This is not necessarily, hey, I've got water where it's not supposed to be, I need to get that up, but that's a dance floor response, right? We're starting to go up to the balcony level. The complex issues force us to go higher and higher, look at it in a more global perspective, it takes us longer to recover. What else? Yes?
The incident. What the incident is.
So give me an example of how the nature of the incident becomes more complex. I'll give you one from my background. Someone decided at the end of a planned marathon to let off 2 devices, and it went into a week worth of response. Became complex, the nature of it. And then all of the cascading things that happened afterwards. How about a snowstorm? Let's do blizzard, a snowstorm with an attitude. Blizzard is not necessarily about snowfall, it's about visibility and wind. And so maybe it shuts down public transportation, so you're not able to switch your staff around. In some ways, like an MCI, we define it, at least in EMS, as when you have more victims than resources. So a minivan full of people and a fully loaded car with elderly people might be an MCI in a town like this that only has 2 ambulances to respond. You might have 6 or 7 victims. If you have a snowstorm and you have your staff that come in for the storm, and now the storm comes in, buries everybody with snow, and you're not able to exchange that staff, you have the same conditions as an MCI. You have staff that are getting tired, they're not being relieved, and you have a certain amount of need that isn't changing. You also can't get stuff in and can't get stuff out. You can't get new supplies in, you can't get garbage out or sharps or Larry's Linens for Less. So the nature of the event can start a cascade. The snowstorm, what if you have an IT issue during the snowstorm? What's the likelihood that your IT help person is going to get on site to be able to troubleshoot that uninterrupted power source or the server closet problem, or everything's delayed, right? So a complex event is one where you are now maybe on your own longer. There is a need for more outside help. It's where your relationships get tested, whether or not your coalition is able to, if you haven't met that person before, maybe you're starting to have more connection with them. So lines and boxes, healthcare coalitions as at the bottom, Our facility is below, the one that whatever in your mind is represented by you. And we're talking about nodes of integration. We're also talking about the access to higher levels of support. So how does the National Guard get mobilized? Can you guys just ask for the National Guard? What has to happen? Yeah, the governor needs to be involved. That's absolutely right. A declared state of emergency, and there's a whole, military and civilian response. But yeah, you can't just snap your fingers and have National Guard. Someone told a really touching story about the National Guard coming to their facility during COVID. It was a story about staff relief and finally having getting to take a break. So that's a great resource. Immediately available to you. Take some time. So you have to anticipate the need prior to, if you wait until you're exhausted and then you start to ask for help, that's like, back to my EMS frame. If I'm in the field and I think I need a helicopter, even if I think I need a helicopter, I should ask for it. Because if I confirm and wait until I absolutely need a helicopter and I have all that time gone, it's that much further out. And so you have to anticipate your needs. Healthcare Coalition will unlock your connection to the Department of Health. They're using incident command, right? They're not saying I want a many-to-one relationship. They're saying use your Healthcare Coalition as the way that you communicate your status, your needs, your anticipated needs. We will gather that information and communicate it to state in the form that state is used to hearing it. That coalition call in the cartoon, it may be, I think it's very realistic. It may come at a time when you're at the at the dance floor in your organization and you're saying, there's another conference call that I have to step away, I have to get on this. The importance of participating in those calls is to make sure that we're all communicating our individual needs. So someone who's higher up in the balcony can say, I've got 3 healthcare facilities that are currently on generator power. I am anticipating there's going to be a need either for more fuel now that the roads are disrupted from the flood, from whatever, or I have a water boil event and several of my facilities don't have stockpiled water. I'm gonna need to prioritize. I need to prioritize at the state level how these resources are gonna come in and how they're gonna get sent out. And so your communication, although it may not seem at the time like, well, I'm currently dealing with this problem on the dance floor, you want me to have a balcony conversation, there's no ranger, there's no cavalry coming unless you participate in those calls. And the more you participate in times of peace, the more efficient those conversations are going to be when you need them. So going up, so regional healthcare, state, we have Homeland Security and Emergency Management. If this isn't obvious to you, the complex piece, recognize that you're the folks from your organization that have been sent to this training. And so the morning was about how do we recognize that there's a need, how do we get the Avengers to assemble, how do we start thinking about our plan and implementing it. But if all of this is foreign to you, it's likely your organization is even more vulnerable because people who don't have an emergency preparedness responsibility are going to be less aware of how it all works. And I think it's complicated stuff, and which is why in your book, in the reference guide, there's a number of resources that have been highlighted for you so that, again, you may not memorize all of the things that we talk about here today, but that you understand you are actually one of the gatekeepers. You're one of the subject matter experts as to how to ask for and unlock additional resources. Who gets to you first, regional or state? Regional, and sometimes they have stuff. Vida, I don't know if in several of our conversations, we've had instances where the region had PPE that was available, had resources. Sometimes they're coordinating information, and sometimes they are actually able to distribute supplies to you. At the state versus federal, do you have anything like deployable medical teams within the state? Okay, so I'm on one from Massachusetts, and at the federal level, we would fall under HHS, Health and Human Services, a department called the National Disaster Medical System. They have medical teams called DMAT teams, they have mortician teams called DMORT teams, they have veterinarian response teams for the animals that are caught up in a disaster, and they are regional. Every state has some capability, and they typically are not sent to the state that is impacted. And that's because the people that are on the team would also have their full-time jobs or their private lives also impacted. So a Massachusetts team will go to Florida, for example, for this hurricane by design, if that's possible. It's not always the case. But it takes longer. As you go higher up on this, FEMA, CDC, HHS, the resources that are available takes longer to unlock them and to get them. So you have to participate in the local conversations in order to have your needs be heard and met and aggregated and then sent up. So there's a number of, I think of them as unlocks. There's a number of things that if you are tracking in your command center, significant events, the time that we activated, the time that we decided to curtail our ambulatory services, the time that we reached out and asked the coalition to help us with fuel because we're low on fuel. The governor's declaration of a disaster is a significant event. There's a form in the world of HICS. You don't have to use it. It's just an Excel form. It just happens to have a name and a number. But this idea of writing down the significant events in the order that they happen, time-stamping them, is important because if you're not in the habit of doing it, once someone declares a state of emergency or a federal state of emergency and unlocks money from FEMA, they're going to make you fill out an application in order to access that. And you may or may not know how many people did you bring in on overtime? How many people did you put in from HR into a role that they're not normally in? Did you get a department ID that had no money in it to track all the expense from your response if in fact you want to get reimbursed for it? And so if you're trying to figure all of that out retrospectively, it's hard to do. It's not impossible, but it is really hard. Hey, Frank, it's Steve. Remember a couple of weeks ago we were responding to, do you remember how much we spent on X? Whereas if you are writing this information down as it's happening, significant events like the ones that are listed up here, you're able to fill out that paperwork and go for reimbursement, or you're able to better understand, the timing of decisions. So there's a bunch of stuff up here, emergency and public health declared emergencies at a local or state or federal level, and with each of them it unlocks certain things that are allowed to happen only during those declared emergencies. So here's an example, 1135 waivers. Did anybody fill that out for their institution during COVID? Clinics under CMS are able to bill for an appointment or an encounter that happens in their facility. It's a licensed facility. It's in a, it's a healthcare exchange in an environment that's designed for it. But during COVID, we couldn't do that, right? We just couldn't let everybody into our buildings and facilities. So what did we do? Virtual, right? We telemedicine. But we were able to bill for it if, in fact, we filled out an 1135. We unlocked the ability to go around temporarily the rules for CMS for reimbursement by filling out an 1135 waiver. Anybody fill out an 1135 waiver for their organization or had their organization operating telemedicine when they don't normally do that? Some heads nodding, yes. It was great access for care at a time where it was really hard to get care to people. It was a super scary time. People didn't know what the impact was of the disease, and so it was a way to multiply our ability. The challenge, if you paid attention to the 1135, if you had a personal experience with it, was that one of the requirements, at least for my client in Missouri, was that you had to have your incident command system running. It was one of the requirements in order to qualify for your 1135. However, all of the people that were attached to their incident command system had no idea that the organization had applied for an 1135. And so somewhere along the line, down the road, the 1135 was in place, they were doing telemedicine, and then they were starting to curtail their operational briefings. In fact, they wanted to recover and deactivate. And finance said, you can't. We have an 1135, and you need to be operating incident command. And so the point of that story is not only is an 1135 an unlock, it allows you to do something that you're not normally allowed to do. I'd encourage you, if you have these unlocks, of having a process where you or your incident management team leadership is tied in at least at a notification level. If not, they have to co-sign the application, so that you now have an incident command awareness that we're operating underneath one of these waivers that is a disaster-related waiver, so that when you recover, you understand the impact. And for those that are familiar with the term, you should be thinking about discharge when you admit someone. You should be thinking about how you're going to have them go back to the community upon admission. You should think about what are the conditions that would allow you, when you apply for a waiver, to not have it anymore, rather than waiting for at a point where everyone gets really used to it, and then others are saying, well, this is a risk because the conditions that allowed us to have this waiver are no longer present. And so maybe having a policy for both the application and the de-evolution of a waiver. 1115 waivers. There are waivers. As a paramedic, I'm not supposed to be giving vaccines. That's something that I am trained at, giving intramuscular injections, but it's not something that I carry around in my drug box. One of these waivers at a state level, under the right conditions, can allow people who are trained in intramuscular injections to start doing something that they don't normally do. It's an unlock. It allows you to expand your resources. It allows maybe nursing students to operate at a level higher than what they're normally allowed to do as a result. Or it allows nurses from a different state to be able to practice. There's immediate reciprocity under a waiver. So having awareness of what unlocks a waiver, it's more than just simply putting it in your paperwork because you want to know when that decision was made. But if you're the one that's more knowledgeable about what these resources are outside, or if you're not, but you know that Levida is, giving her a call and saying, this is the challenge that I'm having, even if I don't know the exact example of what I need to do next, can you guide me? What are other facilities like mine doing? What are my options? So this is just awareness, and again, there's more detailed references in your guidebook. Questions about emergency declarations? These two storms, these two very large disruptions, federal declarations will unlock money to not just have local populations be able to survive for the next several weeks or months, but also the rebuilding effort. And again, that's why it's newsworthy. It's why it's an indicator of how significant something has become. Here are more resources. Again, we said you're not alone, but the way that you operate and not be alone is you have to be aware of what in fact is around you. And again, it's better to know what's around you and meet them in a time of peace rather than trying to figure it out when you are responding. So voluntary organizations, active. So Minnesota Responds, can I ask my region and state table to describe, for those that haven't had the interaction with Minnesota Responds, what is it exactly?
Minnesota Responds is a volunteer registry that is at the state level. So certain regions or counties also have medical reserve corps, and so then they may or may not be federally recognized, just meaning that they have certain trainings and policies, procedures, and how they manage their volunteers at the local level for public health. So typically at your county level, depending on your county, maybe you're a multi-county community health board, but that registry allows for individuals to mark their expertise, their trainings. It cross-checks things such as like nursing licenses. So when individuals are looking to utilize volunteers, and Minnesota Responds is specific to the medical field, or looking more so at individuals who are able to provide support or technical assistance in a medical emergency. More than just a Burgess quote. So maybe it's folks who have EMT experience, they're a retired school nurse, and they're able to be called upon from their local health department if they are available and interested to volunteer in an emergency. And so every local health department has their own requirements when it comes to individual background checks, trainings, how they use volunteers, if they use volunteers, because every agency has their own liability requirements and standards, but it's a great system to track volunteers, and it'll be going through some upgrades in the next few years as well. So some opportunities to offer deployments in the sense of like a timesheet, so volunteers will be able to kind of clock in and out of deployment opportunities when they assist with local health department requests.
So that's a great resource, and I'd love to say it is equally robust no matter where you live, but the reality is it follows the population patterns. So the larger or more dense a population is, the deeper that list is. The other thing to note about these registries is sometimes you could be double counting people. In other words, they appear to have a lot of names of people on it, so it seems really robust, yet many of the people that are paramedics or EMTs or nurses are also committed to an organization that's going to say, I've got dibs on you first and foremost for an event. And so it may not have exactly the bench depth that it appears to have just when you're looking at it. The last thing I'd say is if you're hearing about it for the first time, I'd ask yourself, do you have a process to ask for volunteers, but more importantly, do you have a process to onboard them safely into your organization, right? Your organization might have volunteers. At the children's hospital that I worked at, there were all sorts of volunteers. They'd go through a full new hire orientation. They'd get badged. They'd learn how to navigate the buildings. There was a background check on them. And so when in a disaster, they were like shovel ready. They knew the facility. They even had personal relationships with different staff on different floors. I would use them right away. But I don't have the ability to push a bunch of disaster volunteers through a 1-week new hire orientation in the middle of a disaster. And so what is the quick and dirty? How do I get around if they are going to be interacting with staff? What are the no-go zones? What is the standard reporting going to be for a volunteer? So this registry is great because it's organizing the outside world. Are you prepared on the inside world to, if requested, to receive them and onboard them? Has anybody ever done a drill or an exercise with their local Minnesota Responds group?
Yep, local public health does do annual drills with their volunteers that are registered in their system, and they have objectives that they set ahead of time. We hope to meet that 25% of all volunteers within the registry will respond in state whether or not they would be able to help in this hypothetical situation. So public health does test that registry system and the contacts, and as we know though, emails and phishing emails, sometimes folks mistake those drills and things like that for something that it's not, and sometimes they don't respond, but it is certainly something public health does work also actively in engaging with the Healthcare Coalition as well on where they can incorporate Healthcare Coalition communication drills with their own volunteer drills as well.
It's also great if you're doing drills, and obviously you need to, a lot of the regulation says that when you do a drill, you have to have people who are objective observers. They have to have a criteria in which to observe your drill. And so if you pick internal local people, they might see things that an external person might not. But again, being able to tap into a registry of people who have medical training but aren't necessarily part of your organization might be a way to bring them into your organization to get to know who they are, and they can learn a little bit about you and participate in some of the drills and flex that or grow that connective tissue. Federal deployable teams, we talked about that. There's all sorts of federal deployable teams. There's certain rescue teams, there's medical teams. And so there's a long list. Again, you're not expected to know that, but over there at the table is the group that would know what would be available. So you bring your issue or question to them and they'll help you out. Relief organizations, mutual aid, compacts, EMAC, is anybody familiar with this? This is State Department or Health Department to Health Department from 2 different states communicating and saying, under this compact, we're going to agree to let your medical professionals of a certain type or flavor practice at their home license level in our state, and we're going to do this temporarily. So it's a temporary unlock that allows a impacted region to be able to pull resources from around them. If you're north enough in this state, you could have an I-EMAC, where it's actually the same idea, but it's pulling resources either bringing to or from Canada. So it's an international version of that. And then Strategic National Stockpile, the SNS, used to be run by the CDC. It's no longer done that way. What's in it? How do you get it? Has anybody here ever received anything from the Strategic National Stockpile in your organization as a response? It's not common for sure. I can tell you my experience with it was during swine flu or H1N1. I worked at a children's hospital. What I learned after asking for some of the PPE was that the N95s that came, I think it was like, a couple of cases of N95s, they were all different vendors, which is a challenge if you know about fit testing for N95s. So by the time you're done fit testing, you're out of respirators and drugs. And it came with we had to close the loading dock, and it came with a police escort. And it wasn't from the CDC. I mean, it was, but that's not who showed up. It was state police. And so understanding how strategic national stockpile resources come into your state are then decided where they're going to go and how they're going to arrive. Again, if you're learning all of this because you're asking for it because it's the first time, it just creates that much more of a learning curve for your organization. And so it's great to know that it's out there, but do you have any idea, any references on how you actually make a request and how it will come to your facility? So this is a word cloud. We're not going to dissect this from your phones. If you can just tell us what staff or stuff or space have you received from outside your facility, outside your direct control during an incident.
We had the National Guard come.
You did?
Yep.
Can you tell me more about that? National Guard came to your facility?
Yep. I was working at a nursing home at the time during COVID, and we were really struggling with staff. And we did have the National Guard come in to relieve staff and help out. They didn't specifically do every care, but they helped out so our staff could have some relief. It did take a while to get that help, but it was much appreciated when we got it.
Yeah. I had the privilege, I guess, of responding on the team that I'm on to Lake Charles. Very similar, a federal team going really just as a locum or as a temporary staff. We took over half of an ICU and just ran half of it for them so that people could go home and rest. American Red Cross, I like words of encouragement. Food. The complex event that I would normally talk about is the Boston Marathon bombing. The piece that I will extract from that story that I think is relevant is, as a children's hospital, certainly around holiday time, we receive a lot of donations. So we have a pretty robust process for receiving in-kind goods. We're not prepared for what came in out of kindness in response to the marathon bombing. It overwhelmed our process by a factor of 10. And it's the kind of thing, would I plan on, do I have a plan for generous gifts coming into my organization? But point of fact, it's a disruption, right? At a time where we're trying to stay focused with all this in-kind stuff coming in, it has to be managed, it has to go somewhere, it has to get vetted. Food, always wonderful, always welcome. You got to know where it's coming from, that it's safe to give out to your staff, but it's wonderful to say thank you. Space and PPE, masks. The crocheted mask that Mia was talking about, that was one of our first in this series. Someone was sharing that story with us. I thought that was adorable.
We had a boil water advisory last year, and some of our local churches brought bottled water into our facility to help us out because it was a 2-day process where we could not drink any water.
How many stories in your facility?
2.
And how easy is it to move water vertically in your building?
Not very easy.
Yeah, it tires people out pretty quick, right? And then you also just have half-drunk water bottles everywhere. For those that haven't had to live through water boil, it's conceptually it's not hard to wrap your brain around, but it is hard to manage logistically. Sometimes we buy 5-gallon containers and a dolphin pump, but they're really hard to move and really hard to kind of distribute the water. I think having at least round one of the small individual bottles and gallons can be really helpful because you can move them a little bit easier. Is that great?
Well, and the funny part of that story was some people were not understanding the whole situation. And they were taking the jugs of water to flush the toilets versus you don't need fresh water to flush the toilets. So that was just, it was a lesson learned.
So it's not just about having the stuff, it's also about being able to communicate, right? Because now we're going to do something that we don't normally do, and we might have to not just give out water, but also some instructions, and yeah. Thanks. So that's Module 7. It gives you a flavor for complex events. Again, they're not as common, but when they show up, you know, they're really not great. They kind of tire you out, make you feel thin in an unhealthy way. But there are resources that are outside of your immediate scope. That 5 Days at Memorial book, I don't know if I forget if I've said the same soundbite in each place, but 5 Days at Memorial is a story about a hospital in the Hurricane Katrina, and essentially they de-evolve, right? They go through days where the toilets no longer work, there's no power, the place gets hot and sticky and smelly, and those that can get out do, and for those that can't, they don't, and there's some clinicians that stay behind. And they don't realize what the resources are that are a few miles away. They just don't. They are living in this really tough situation. And the way the book reads, it's a story about feeling isolated and wanting to stop suffering of their patients. And so there are trials and people lost licenses. And so there's a whole tragic ethical component to the book. But there's 2 points about the book that I think are worth communicating. One, if you don't learn and practice incident command in time of peace, you'll figure it out during an event like that if you're unfortunate enough to live through it, because it's what smart people eventually figure out, except you don't want to actually invent this system and teach it to yourselves in those conditions. And the second is there are resources. So often there are resources that are available to you. They may not be immediately obvious to you, but that's the whole important piece of reaching out to your healthcare coalition, or getting of the few messages that get out, getting out to the communication that says we are in trouble, we need help, so that can be prioritized for you. And then here's where you write yourself a love note, right? What actions would you take from the complex events section?